Oh, that's not good. Okay, welcome everybody to Grand Rounds. We'll be talking about frontotemporal degeneration, frontotemporal dementia. Attendees, remember to sign in. I assume the materials are in the back of the room. Sign in so that you can get CME and complete your evaluation forms so that you can get CME. Resident will be a brief all-resident meeting immediately following Grand Rounds today. So today we have our own Dr. George Newman. He's the chair of Neurosensory Sciences and director of the stroke program here at Einstein. He's one of the favorite attendees among the residents who are rotating in neurology. His PhD is in membrane biophysics. His interest is in the mind-brain interface, and it leads to childhood, and was expanded while he was an undergraduate in Haverford College. He's given a prior psychiatric grand rounds here on the prefrontal cortex and free will, which I remember fondly. He enjoys learning new things and currently plays banjo. We'll expect a demonstration. Speaking Spanish, learning to draw, and the pathophysiology of frontotemporal dementias. We have Dr. Kabasakalian. Yeah. Okay. He'll be joining Einstein March 1st, so welcome. She completed residencies in both neurology and psychiatry, which is impressive, as well as a fellowship in behavioral neurology with Dr. Kenneth Heilman at the University of Florida. He's considered one of the fathers of behavioral neurology. And we also have our own Dr. Mike Iovacchini. He's an intern here in psychiatry at Einstein with a bright future ahead of him. So please join me in welcoming our panel for today.
Thank you. I'm just going to start off real quick, and then I will get out of the way. This is in 3 parts. Mike and I encountered a patient up on Tower 7 when we were doing neurology consults, and that patient is the foundation of this grand round. So Mike will be presenting a lot of the aspects of him. Dr. Kabasakalian, who, as you heard, will just be joining us now, will give us the clinical spectrum of frontotemporal dementias, Pick's disease, which is the behavioral variant of frontotemporal dementia. And I'm going to come back in whatever time is left and talk about pathophysiology. I also will have a clinical comment or two. And so without any further ado, I'm going to play with the computer and set Mike up. Almost like common sense. Life wasn't so easy this morning. No. So,
all right, nice to see everybody, and thank you for having me. I'm honored to be here, and thank you once again, Dr. Newman, for letting me be a part of this. All right, so obviously this is the Psychiatry Department Grand Rounds. We're presenting a neuropsych case here, so I just wanted to briefly mention that I had the pleasure of going to a conference with Dr. Roby as well, and we're kind of going to be putting this initiative of just trying to get everybody involved in kind of merging our 2 departments or getting an interest group going. And on just a brief caveat, I saw everyone who presented up there include their universities in the corner. So there are mine: Penn State undergrad, Midwestern for med school, and Einstein. Proud to be here. All right. So this is a clinical case. It was during my first month of residency. And the teasers, some things it involves are capacity, non-compliance, elopement, and power of attorney. So the case, the patient's name is Michael, 58-year-old male with no past psych history, history of TBI in his 20s, from a fall from a ladder. Came to the crisis center on a 302 petition by his sister. He was aggressive and had inability to care for himself. She had seen his apartment over the last couple weeks, and it was very disheveled and a mess, more or less. So the 302 reads: my brother's depressed and acting bizarre. He's disheveled and malodorous, hasn't bathed for over 30 days. He's lost about 10 pounds in 30 days. Staying for a job that he was fired from a year and a half ago. Forgets where he parks his car, wandering into people's houses and yards. His girlfriend had a restraining order on him, and of note, he was found walking in the rain with a trash can on his head. Needs to be evaluated. So when he got to the CRC, they directed him for up to our ED. So obviously, you guys can picture that, right? What are our first thoughts when we see somebody walking down the street with a trash can on their head, covering from the rain? It's a makeshift umbrella, you could say. What was that? Smart. Sure, resourceful. I like that one, resourceful. So we sent him up to our ED to get medical clearance. He had no substance use history or no past psych history, and he was obviously needed to be evaluated further. So he was medically cleared. He got a neurology consult. I'm just kind of listing off some things that were done in the ED. The drug screen was negative. CT of the head had no acute processes. All labs were negative for any acute abnormalities. He did require episodes of restraints and sedation for aggression to staff. He consistently said things like, so he didn't believe who the physicians were, and therefore refused to give them information. Also, he stated he constantly wanted to go back to his job. I need to get to work. And there was a report about how he had gone to work, demanding to work. He had been fired a year and a half ago, and then he got upset and trashed his boss's office or the union's office and had some trouble with the staff at his workplace. He denied that event occurring, and then made statements like, "This is wrong, I do not want I'm here, I need to go to work." He's dirty and disheveled. Wife had stated that he was grooming himself meticulously, so angry and agitated as well, and unwilling to calm down. He denied paranoia, but repeatedly, once again, I stated that he refused to give us information because he didn't trust who we were, didn't believe that we were the medical staff. Otherwise, he had been in good health. The only medical history is that TBI 30 years ago. He had no post-TBI epilepsy or no cognition issues at work. He was divorced, and his sister believed that he was depressed for several years after. And then the memory issues specifically were, over the past 2 years, he had progressive memory issues. Like we said, he'd been walking into people's yards. He had been parking his car. Here, so I'll just kind of read some other things. Started to walk in other people's houses. Constantly lost his car, and when he came, I remember them saying his car had been missing for about 2 or 3 weeks prior. The ex-wife kind of more or less corroborated exactly that, and I'll just kind of pass through that here. The neurology service specifically said that he is not appropriate for the neurology floor. Stated that he needed a further MRI, and because once again, we had the CT, we had an initial set of labs. It was a CBC, CMP, chest X-ray, and a head scan of the CT of the head. We had no other information to work with, more or less, throughout our hospital course. But that was his initial evaluation. MedRec, there's no current medications. When he got to Tower 7, he was asleep. You know how we do when we get patients who come in, potentially psychotic, potentially aggressive, and they've been sedated. When they come up and we want to let them sleep, we let them sleep. So once again, I just kind of highlighted, bolded here that breathing calmly, because when obviously somebody's been in restraints, psych residents, you know what to do. You check their respirations, you check if there's any injury. So I just wanted to include that. Other than that, PDMP, he had a Percocet filled back in 2011 one time. So psych review of systems at the time of presentation was obviously difficult to assess, other than agitation. Medical review systems, he refused interviews constantly, and so this is kind of giving us the idea of what we're working with. Vitals were stable, other than a slightly bradycardic pulse. Physical exam, patient refused. The neuro exam, within more or less refused as well, but some things could be done through observation. Normal appearing gait. He was alert and oriented ×2, only to person and place, but not time or situation. Mental status exam, motor at the time, normal gait and movements. He was unkempt, dirty, malodorous, fair eye contact, fair rapport. Speech was impoverished. Mood stated I'm okay, but his affect was blunted and incongruent with his mood. His thought process was confused. Thought content, he denied suicidal or homicidal ideation. And perceptions, he was mildly internally preoccupied and paranoid. Insight and judgment rapport, once again, mistyped that there, oriented to person and place only. And memory, his long-term memory appeared to be intact, and that's all we could more or less evaluate at the time, given a limited interview. So the assessment plan, obviously, we were considering a differential at that time of psychosis. We were also considering a form of cognitive impairment. I won't, bore you with all of this, but in summary, to kind of wrap up like what we had said, we only had a CT head, chest X-ray, CBC, CMP, and then his limited history. Dr. Newman very kindly figured out some technology improvements from this morning session. So now we have his CT scan. So you can see this right-sided frontotemporal region that looks more or less pretty abnormal compared to the other side. And laser, beautiful, perfect. Anything else you wanted to point out? Some frontal atrophy. There we go.
This used to be the temporal lobe. This used to fill this space. This used to fill this space. So this is 1/3 of the volume of the sugar.
And I will admit, to be completely honest, as a new resident, within, this patient presented within the first maybe 2 weeks of my residency. I didn't really know how to even work the computer system to go back in and look at CT scans yet. So I read the report, of course, that says no acute pathology. Great, so his CT's negative. And we went from there until obviously Dr. Newman astutely came on and said, hey, let's take a look at that again.
This is the, just stay with that for a second. This is the temporal horn. The temporal horn on the other side, the saying is, if you can see the temporal horn, it's enlarged. Okay? So this is, and this relatively young man, even this is enlarged. This is grossly enlarged and tells you that there's severe atrophy, amygdala, hippocampus, parahippocampus, receptor, as well as this, you'll see other pictures, but this is a severely atrophic temporal lobe.
So briefly, I'll just talk about his hospital course. Once again, on the unit, after being sedated and restrained.
They said no acute process on CAT scan. Did they comment on that actively?
No, and that's
acute,
It's not acute. Right. That's what they said. There's no acute pathology.
And I'll just refresh my own memory and you guys as well, that this was a progression over about 2 years, 1.5 years to 2 years, which is pretty quick when we think of cognitive processes or a potential dementia.
Why did he divorce his mom?
That's a good question. Potentially, yeah, that's a good question. And we had significant collateral from the sister and from the ex-wife, and actually that was the one that I had kind of skipped through. But I believe that, go back really quickly if you'd like, but I believe that likely, like you said, this might have been a longer process than 2 years. Sister had stated, so per the ex-wife, we have a history of 3 years, acting erratic, acutely worse over the past year, memory deficits and argumentation. So potentially that led to divorce in his case. All right, and then like I said, I'll just quickly kind of do his hospital course. On the unit, he was not aggressive. At times, he did get agitated. He had no psychotic symptoms at any point during his hospital stay. No hallucinations. Minimal amount of paranoia on presentation, but less so as the hospital course went on. He did elope one time, which was kind of a funny story. Very briefly, he eloped out of Tower 7. Obviously, you know Tower 7 and Levy 9 connect. What was funny, though, is that he eloped and he was out of the unit for about 15 minutes, but at no point made a left for the exit sign to go downstairs. So the whole time, he was just pacing the hallway, more or less aimlessly, and we found him. Also, we had initiated him on Risperdal when he first came in due to agitation, and Prozac midway through the hospital course as an SSRI to help manage some of the behavioral symptoms that he was exhibiting. And then we also had the result of non-pharmacological intervention afterwards. In summary, the patient was diagnosed with frontotemporal dementia. We wound up discontinuing his medications because he more or less refused them continuously. We did have issues with getting the sister to become the power of attorney. She had more or less called and said she was going to come and visit him several different times and was unable to. And then lastly, I will say that she wrote him a letter saying, hey, this is your family, we love you, we know you're in the hospital, and we need you to stay there and get treatment. And we wound up giving him that letter, and he was able to hold on to it pretty much every day, and that was part of our redirection of the non-pharmacological management. And he would read that letter, and it would kind of decrease his level of perseveration. Just a couple of other quick things. The behavioral observations that we made, I'll wrap this up. He did exhibit, these are some of the behavioral observations you'll see in frontotemporal dementia, but Dr. K is going to get into that in a little bit. He was disinhibited. He was approaching strangers out on the street previously and starting fights. Hyperkinesis, or in our case, we would call it maybe psychomotor agitation. He constantly had this pacing at the nursing station. And I don't know if you guys remember, if some of you, Marty, for example, on Tower 7 may remember, he had this perseveration of speech as well, where he would constantly pace at the station and go, I just need my boots and my wallet and my keys so I can get the hell out of here. I just need my boots and my keys and my wallet so I can get the hell out of here. And that was more or less a consistent daily process for him. And once again, I mentioned the letter, the speech, the pacing, and then, and then long story short, he had been seen by one of our other attendings, Dr. Redamero. He was seen in a parking lot post-discharge where he was agitated and approaching strangers. And she, obviously felt bad for him in that case. And, obviously he's at risk of getting himself into trouble by approaching strangers who don't know his history. And then also, lastly, I was in the ER a couple days ago, and right before we had this presentation, I saw his name pop up on our pre-arrival list, and I was really hoping that I would get to see this guy one more time right before we had this presentation. It would have been serendipitous, to say the least. But either way, I think it still worked out because the pre-arrival list, even though he never came, stated combative with history of dementia. So we obviously understand that he had this continuation of behavioral symptoms that more or less are going to be progressive throughout the rest of his life. Dr. Newman had a very quick story about something that was of note.
Thank you. So I will just add one thing to Mike's presentation. So when we saw Michael on the floor, what was notable was several things. He was constantly moving. From the movement, you could also, insofar as you could do a motor exam, that was it. His motions were fluid. He was well coordinated. There was no evidence of weakness, limp. He had no facial weakness. His posture was normal. So most of the sensory motor system was certainly working normally. His language was normal when you spoke with him, maybe a little bit of paucity. The only thing was he was fluent for sure, and he just either obsessed or perseverated on a single topic. He wanted his wallet that day. The day before, he had wanted his boots. They actually gave him his boots, and so he stopped talking about getting his boots back. But that day, when we saw him, he wanted his wallet back. And he would just be walking around, and he created, you had to get a sense that there was a space that you could not get into. He owned this space, he created this space with his movement. And he was constantly talking about the wallet. I just need my wallet back. When I get my wallet back, then I'll be able to be okay. And I'm not going to do anything. You can't examine me. I'm not going to do anything until I get my wallet back. When I get my wallet back, then I'll be part of this. And that's what he was doing. I did not feel any threat from him at all. There was no, although you could say that he was agitated and had been earlier in the hospitalization, at that moment, there was no sense of any threat of any kind. And so, I don't know exactly why, but I simply intruded myself into his space. And then I asked him a question. And it was a medical history type of question. And he stopped, and he answered the question. Okay, just as plain as could be. Focused on it, understood the concepts that I was giving, gave me a straightforward answer. Then he backed away from me and started moving. He said, I see what you're doing. I'm not going to answer any more questions until I get my wallet back. When I get my wallet back, and no more, I'm not going to put up with that anymore. And I just went, okay. And I just stepped right into his space again, and I asked him another question. And he stopped, and he answered the question just as ordinarily as could be. And then he backed away, and he said, no, I'm not going to be doing this anymore. You can't, when I get my wallet back, and until I get my wallet back, I'm not going to be doing anything. So I stepped into the space one more time. Mike, I thought, was going to be thinking he was going to need to pull the guy off me. And once more, he just focused, answered the question as plain and ordinary as could be. There was nothing wrong with his answer. And then he started off again, and I thought, that's enough. I could do this all day long. But he was not capable of inhibiting his behavior once I intruded him to the space and the question. He was stuck. Okay? He did not have any flexibility or ability to say, you know what, I'm not doing that. I'm not. There's none of that. He had to answer the question. Okay? So Dr. Kabasakalian is going to get into the clinical aspects of this spectrum of disease. Right. You need to, sorry. Yeah. So, is this yours?
Oh.
So, is this yours?
This is mine.
Okay. Fine. Okay.
Oh, is it back? Oh, I see. I'm going to start on this screen just to clarify naming. So frontotemporal lobar degeneration, I'm going to be referring to as frontotemporal dementia. I think those are sort of used interchangeably to some degree. So what they are, they're a cluster of neurodegenerative disorders, although there's also some variation about possible etiologies, pathological etiologies. And they're characterized by atrophy of the frontal and temporal lobes. So in this,
Ignore me.
oh, no, where, is that I'm sorry. Oh, so anyway, so in this picture, I'm not sure what this is here. The arrows are pointing to, if you see the black space anterior to the central sulcus, you'll see there's just space, right? So there's atrophy of the frontal lobe, the medial frontal lobe. In this one, you can see on a coronal view that it's just missing. It's just gone. I mean, there's atrophy of other areas of the brain as well, but here's a picture of the missing frontal lobes. This is a semantic dementia, which is a variant, and I'll talk more about that. But here you can also see there's basically this is huge dilatation ex vacuo of the left temporal horn. There's pretty significant atrophy of the right temporal lobe as well, but there's some asymmetry. Okay, so let me go on. Oh, cool. Thank you. All right, so phenotypically and pathologically heterogeneous, although some people consider it a spectrum. I think there's some ongoing discussion about what it is or what these things are. The incidence of frontotemporal dementias is 1.6 to 4.1 cases, new cases annually per 100,000 people. And there are 20 to 30,000 people at any given time in the United States who are affected by frontotemporal dementia. There's a peak prevalence of 65 to 69 years. I had that before. I believe it's the number 2, the second main degenerative dementia for patients under 65. So there are 3 core clinical phenotypes. The behavioral variant, which is what we had described initially here. Then there are 2 which are part of another category of disorders, the progressive dementias. There's a semantic dementia, which is a primary progressive aphasia, which is similar to Wernicke's in some ways, but it doesn't involve repetition. Repetition isn't impaired, so it's more of a cortical variant. And then there's a primary progressive non-fluent aphasia, which is, I'll describe. So there's this third variant, this is sort of a digression, there's a third variant of primary progressive aphasia, just so you know that not all primary progressive aphasias are subsets of frontotemporal dementia. And this one is more posterior, has different speech degeneration, and is thought to be due to Alzheimer's pathology. So The behavior variant, as was described, affects mood and affect, personality changes, executive function deterioration, other behavioral changes. When you think of the frontal lobes, the main function of the frontal lobes is to integrate perceptual experiences, internal, external, environmental, and help you adapt appropriately, contextually, into the greatest advantage. And in this disorder, which is the behavioral variant, we see a deterioration of that. Mood can be irritable and happy. Autistic can be both. The patient themselves can be happy but not want to be interfered with by anybody. They can present as irritable. I've seen some hypomanic, manic presentations. There's a loss of insight and judgment. So they're not able to judge contextual appropriateness of their behavior. They can be hypersexual. They can be hyper-religious. There can be emotional dysregulation or apathy. There's impaired decision-making, less attention to personal hygiene, deterioration of living environment, all of which were described in the case that Michael presented. There's also a decline in executive function, planning, sequencing, organization. There's loss of spontaneity. Now, I wanted to distinguish between impulsivity and disinhibition and loss of spontaneity because I think it's an important distinction. So impulsivity and disinhibition are not volitional. I mean, to the degree that behavior is volitional. Whereas spontaneity is the ability to act without hesitation in an appropriate context, taking into account all the elements that your behavior will affect and all the elements that are going to influence your decision or whatever you want to call it about how to act. So that is lost, and you're left with sort of this behavior which is not regulated and not contextual. There's also an impaired initiation and completion of tasks. This may have to do with some of a number of different executive functions or drive to complete them, like you can't sequence, you start things, you intend to start things, you lose interest, you don't want to follow through, it's not interesting to you anymore, the novelty's gone, or you can't figure out which one to do first. I've seen a number of different discussions about why people can't follow through. And the other thing is that then things get left undone all over the place. And there is, which is consistent also with this deterioration in living environment. You can't maintain order in your life, internally or externally. And so, and another feature is that behavior tends to be in frontal lobe syndromes environmentally driven. In other words, and that's what Dr. Newman was kind of describing. I sort of was interpreting this resting state mental status of the patient with the pacing around, which was superseded by Dr. Newman stepping into a peripersonal zone and becoming a more an object or whatever, an intrusive stimulus of greater valence that held his attention for a while, and then he stepped out of it. And he couldn't inhibit his response to that environmental stimulus. Okay. Semantic dementia is a really interesting dementia. This is actually the opposite of what the patient had, because the patient had asymmetric, relatively greater asymmetry with right temporal lobe atrophy greater than left, right? I think that's what we saw. So in semantic dementia, the earliest features are anomia, meaning you can't find the words to this thing, and it becomes progressively worse. And then you have circumlocution, which is You know the thing that you use to point at the screen that has the red thing on it. So there's a degradation, not just of language, but of the concepts that language encapsulates or represents. So the early features of this loss of naming and annoying, like, oh, I'm getting older, I can't remember words, but there's a degradation of concepts where things lose the things that make them distinctive and degenerate into less and less distinctive or atypical features. They become more typical. Ducks, birds, duck becomes bird, bird becomes animal, animal becomes living thing. And this is it's a type of degradation that you'll see. It's sometimes really well illustrated. I'll show you an example. So animals, when you get people, this is a typical degradation. Animals are classified as four-legged with a tail, and you'll see this repeatedly in people who have loss of semantic representation of an animal. So this is a duck, not with 2 feet, not with feathers, but with 4 legs and a tail. This is a camel. We see that on the mocha. Which I actually think is I like the mocha for this reason. And I often ask about the typical features. What is this and what's the name of this? So then I get a naming of a part and a whole. But anyway, so what you'll see here is as we go down, there's a degradation of this typical feature, and this degrades into a 4-legged animal without a hump with a tail, as does the duck as a 4-legged animal with a tail. And the beak kind of loses some distinction as well. It looks sort of like a dachshund with a very long neck and 4 feet. So this happens, they lose understanding of their world and their representations of their world. It's not just a language thing, that this gradually deteriorates as well. So I just want to go back, but by the end, the language is called, it's semantic jargon. It's got a prosody is normal. If you're listening to it and didn't know English, it would sound normal to you. It seems grammatically correct until you actually listen to the words and notice that they don't make any sense. It's typically left temporal lobe, temporal pole, and then other parts of the medial temporal lobe are involved. So the primary progressive non-fluid aphasia is a different presentation. There's a greater difficulty in getting out speech. I believe repetition is also preserved, so it's similar to a Broca's so sort of a cortical expressive aphasia. And so speech is progressive, agrammatic, there's halting speech, it's really, really difficult to initiate. And it could also be apraxic. In other words, so the motor speech programs to get the speech out are impaired. Okay. So as you'll notice, these language areas typically are left hemisphere dominant. So these are probably better described because they have language involved. I think it's more difficult to describe right lobe functions. But so we did have this good description of this guy, and so there are these characteristic personality changes, inappropriate behaviors, although that is a frontal lobe feature. Prosopagnosia, which is atrophy of the fusiform gyrus, inability to recognize familiar faces. I actually don't know topograph-agnosia. I should have looked that up before.
Spatial disorientation.
Is it? Okay. So let me go on. I would imagine that there's a loss of prosody and other non-verbal language characteristics that go on with the left temporal lobe, anterior and posterior, that correspond to the right temporal lobe that correspond to left language loss. So this was interesting. I saw this patient who I was sort of a fellow in a motor movement disorder clinic for a little while, and I saw this patient came in with Parkinson's, and he was referred by the psychiatrist who referred him to this Parkinson's specialist that I was working with. But the first and he described a 9-year deterioration, but the first 4 or 5 years were solely involving language deterioration, the concept deterioration. He was aware of it. He was not really disinhibited. There was some frontal lobe impairment, but it wasn't as pronounced as you might have thought. He had relatively good receptive language, relatively, but there was some loss of concept. I'm bringing it up for a couple of reasons. First of all, I looked it up after that because I hadn't seen primary progressive aphasias in the context of Parkinsonism. And there are a couple of cases described. So here's my public service announcement is if you see it, describe it so that the next person who sees it can describe it also, and we develop a literature of all these syndromes that are not adequately described. But what really bothered me also was that the physician who was seeing him said, well, I'm a movement disorder specialist and you have Parkinson's, when it was clearly, and what bothered me was that the family then didn't have an adequate explanation for why the 5 years preceding the Parkinson's occurred. So then when he left the room, he said, I'm a behavioral neurologist, and what happens is this, and your language is deteriorated, you probably have the primary progressive aphasia. Naming something for a family is invaluable because a lot of, the general population and people who don't deal with cognitive issues don't know all the various dementias, and it can be very useful to have an explanation for what's going on with them and their family member, because it doesn't necessarily correspond to what people describe as Alzheimer's. And then they go, oh, and then they understand better what to expect of the person and how to take care of them, what to anticipate decline is going to be like. So that's an aside. There's another variant, which is the anterior lateral sclerosis or motor neuron variant. I think initially ALS or Lou Gehrig's disease was supposed to be a primarily motor disorder, upper and lower motor neuron, but it became recognized that frontotemporal dementia was also associated. So, the more we study these disorders, we find out they're not exactly what we thought they were in the beginning. Parkinson's disorder, which was also supposed to be a primarily motor disorder, has very clearly described cognitive features associated. So don't be stuck in somebody else's description of the disorder. Okay. Oh, that's you.
Thank you.
You're welcome.
I need the.
Oh, yes. Sorry.
All right. Thank you.
Whoa. Should I stand next to you?
Thanks.
Sorry.
Lucky I haven't put it. So, right. All right. What brings these groups together is their pathology, actually. So we wonder why we're putting ALS on the same page as frontotemporal dementia. And it has to do with the pathology. And it is now being recognized that that there appears to be a commonality or common pathway of degeneration that is occurring in many of these diseases. And I thought we'd take this opportunity to introduce you. I'll be quick. I know we want to leave some time for questions. The gross pathology of the frontotemporal dementias is atrophy of the frontal lobe and temporal lobe. That's why they're called frontotemporal dementias. When you look microscopically, I'll show you, you see a very particular type of pattern that was originally, that took us to the end real quick. been challenged with this thing all day. There we go. Here's the growth specimen. So here's the type of temporal lobe atrophy that we've been talking about. Here's the microscopic, although Pick first described this disease, which say back in about 1860. It was Alzheimer, actually, who brought together the pathology. And he called these Pick bodies, although it was Alzheimer who described them. These are proteinaceous inclusions, is what they are. This is a silver stain, not an immunostain, but a silver stain. The silver is binding to complex proteins, is what's happened, precipitated proteins. All of the proteins which are involved in this disorder have a prion-like domain. So we're going to come back to this. This prion mechanism is important. I want to introduce you to the proteins first before we get into prion. In ALS, the vast majority of the proteins that accumulate in the cell are a protein called TDP-43, which I will introduce you to. In frontotemporal dementia, that's half of all the cases. There's another 10% of proteins which are related to the TDP-43. I'll introduce them. And then 40% of them are tau proteins, which is the same sort of thing that you see in Alzheimer's disease. Here's the pathology in Pick's disease. This is an immunostain for tau protein. This is obviously from one of the patients with tau. And these are the fibrils that are going to form. These are proteinaceous crystalline structures, really, is the way that I think about them. All the black dots is immunostain for tau. Tau is a normal part of life. It's part of the microtubular system, and it is responsible for stabilizing microtubules in the neuron so that they can have their nice long axons or nice branching dendrites. The tau protein is responsible for that extended array. In frontotemporal dementia, you'll see that, and especially in Pick's disease, okay, you'll see that tau is accumulating in the cytoplasm in a form that is hyperphosphorylated. Again, this will make sense as we go through this. Here's staining for the TDP-43 protein, so these are in patients with frontotemporal dementia. Now, with the exception of tau, all other proteins that accumulate in the frontotemporal dementias and in ALS, okay, are involved in this nucleocytoplasmic transport. So let's explain this. Transcription, that is DNA to RNA, occurs in the nucleus, right? But translation, that is RNA to protein, occurs in the cytoplasm. Therefore, RNA, which is synthesized in the nucleus, has to be transported into the cytoplasm. And then the protein has to be returned to the nucleus. That's the problem in most cases, in all cases of ALS, and in 60% of the cases of frontotemporal dementia. That is, that there's a problem with the transport of the protein back into the nucleus. And so these proteins, which they are transport proteins, but they normally are only found in when you stain, you only find them in the nucleus. In frontotemporal dementias, you find them out in the cytoplasm. And normally, they are only rarely out there for a short period of time. The TDP-43 protein is a highly conserved protein. This is fundamental. You see it in archaea. You see it in all eukaryotes. This is not some specific neuronal protein. This all cell types uses TDP-43 protein to shuttle the RNA in and out. You have over 1,000 protein targets in a normal cell. It's involved in RNA transcription and RNA splicing, processing out in the cytoplasm. If it doesn't work, you end up with cell death. It's normally involved in neuronal plasticity, holding the dendrites intact. The whole thing just starts falling apart if this system doesn't work. The FUS protein basically is a group of proteins. This is just an acronym. The F actually is a particular sarcoma-related protein. Just like TDP-43, these are ubiquitous proteins. There's nothing specific about them. They are necessary for the cell to function in order to synthesize protein. They are necessary, and any failure of them simply destroys the neuron or any other cell where they occur. Any mutation that holds those proteins out in the cytoplasm can cause frontotemporal dementia. And there are several different ones, and there's no point in getting into them. There's a mutation which prevents the TDP-43 from coming back in. There's the mutation which takes the FUS protein, and it's a failure of methylation, but as a result of that failure of methylation, it accumulates out in the cytoplasm. This is the nucleus with its, these are nuclear pores. These pores, these nuclear pores are huge. These are huge, okay? Just to set it in perspective, if you think about the core of an ion channel, the calcium channel, the potassium channel, okay, voltage-gated channels, okay? The pore is 1 nanometer, okay? This thing is 120 nanometers across. This is massive, okay? And this is how all of the RNA goes in and out of the cell. And there are systems to bring it into the nucleus and to get it out of the nucleus, all right? And here's another, this is a common gene mutation that occurs in frontotemporal dementia. And in this case, what happens is you get this repeat, which is on the recognition site, so it can come in and out of the pore. And instead, you get this, instead of 2 to 20 of these repeats, you get hundreds to thousands of this nucleotide repeat sequence. And as a result, it can't be transported back into the nucleus. So again, the common theme, whether it's tau that's accumulating in the cytoplasm or these other proteins, in all cases, what you have are these proteinaceous materials that accumulate in the cell. Now, that's not the problem. The problem isn't just that the proteins are accumulating. The problem is that all of these proteins have prion-like domains. All right? So you may remember the term prion from Stanley Prusner's and Carlton Gajdusek's research with Kuru. All right? And it was thought that these were proteinaceous particles which were thought to be infectious or are infectious. They had no RNA, they had no DNA, and yet they were infectious. Okay? They came from cannibalism was the story. But this mechanism, this prion-like mechanism, is not restricted to these rare infections. In fact, most of the neurodegenerative disorders appear to be focused on this prion mechanism. And so every one of the proteins that is involved in frontotemporal dementia and ALS, every one of them has a prion-like domain. That means that given the wrong set of circumstances, they can aggregate as beta-pleated sheets, make amyloid basically, and like I called it a pseudocrystalline array. So that's number one. And then the other thing is that you can take a lot of this protein, so these are misfolded proteins, basically what they are. So you can take a lot of the TDP-43 and put it in a test tube. And then if you take one of the crystals of the misfolded TDP-43 and throw it in with those, boom, they all misfold. They all, okay, so that's the sense in which this becomes infective. Once the protein misfolds, the misfolding propagates because all of these proteins have prion-like domains. Okay? I'll get into that a little bit more. The other thing is so that they can infect the cell and all the proteins fall apart and misfold. But then, in addition, whether through synaptic transmission or what's called macropinocytosis, they are able of transfecting the next cell in the synaptic pathway. And that's why you end up with these systems degenerations where you have one neuron chain after another that precipitates, okay? So there's a great cartoon. So here you are, here's a misfolded protein, these are normal proteins. This comes in contact with this, they all misfold. Then it releases it into the extracellular space. Then it's taken up into the next neuron by macropinocytosis, and now it has the same problem. And so you propagate this misfolding of these proteins, and that's the prion mechanism. And in all cases of at least frontotemporal dementia and ALS, this is true. Here's the TDP-43 protein has this is known. All the proteins that do this have this glycine-rich area. And why a glycine-rich area? Okay, because that's how it gets through the nuclear pore. That's the recognition that allows it to migrate in the nuclear pore. So these proteins all have this glycine-rich region, and they're all capable of misfolding. Here's the tau protein. These are microtubules. These are MAP proteins, microtubule-associated proteins, MAP proteins, including tau. Tau is a MAP protein, all right? Here you have paired helical filaments. Look at those. You can see those really beautifully here. These are not microtubules. These are just tau, just pure tau, okay, that has taken on this crystalline array. This is what we're talking about, the prion mechanism. All right? And all of them have been shown to be capable of transfection. As far as our patient Michael goes, there is one particular variant, and I'm just speculating here, but there's a particular variant where you have one of these FET proteins which accumulates. They present with just psychobehavioral, normal motor, normal language, and psychobehavioral disturbance. So basically, I think that's it. All right, yeah. So let's get everybody up here and we'll take questions. I think one of the things that I would like to have Mike and Ani talk about is the differential diagnosis a little bit here. In particular, how do we separate these patients from schizophrenia? How do we separate these patients from Alzheimer's disease? Yeah.
Given the genetic changes that lead to abnormal folding and the improper transportation, is there a way to form some type of a sample so that you could do the genetic sequencing to make the diagnosis?
I think, and so the answer is yes, okay, although we're at very early stages of this, but I don't think anyone has found a mutation in the tau. Now, in the TDP43, there's a known mutation, and yes, we should be able to screen for that. Although you'd have to screen for it off the gene because the protein is a brain. Well, that's not true. We'd see the TDP in other organs as well. So yes, we should be able to. There was that C92 FRO that is now recognized to be it is capable of testing it for.
And can we look at the multi-repeats at the tail end?
Yeah, right, and right, that multiple repeat also, although those multiple repeats only, as far as I know, only occur in brain. Why they don't occur in other organs, I'm not sure. But yeah, I think we're going to be seeing, and Ani and I were having a discussion before, I think also it isn't only mutations, because there's probably going to be, I think we will expect to find autoimmune disorders, which are also capable of holding those proteins out in the cytoplasm and then precipitating them. So I think we will eventually discover all of that as well. Yeah. Okay. Either of you want to talk about the differential? I'm sure you had some comments on it.
Yeah, I had some slides earlier this morning that I was able to address, but we had some funky technology issues and then time this afternoon. So really quickly, we were talking about the differential of FTD. The two most common things that we think of are schizophrenia or Alzheimer's dementia. The things that we were kind of briefly just saying that differentiate them are age of onset. So obviously in schizophrenia, we see a much younger age of onset, although in frontotemporal dementia, we can see it as early as in their 20s, but most commonly in the 6th decade of life. Michael, our patient, was about 58, so kind of fits pretty closely with that timeline. Also, it had more or less what looks like a rapid cognitive decline. He declined over about 2 or 3 years. And so I believe that's a little bit faster than we'd see in something like Alzheimer's, correct? So this schizophrenia as well would present with the psychotic symptoms, hallucinations, paranoia. We did see a little bit of the paranoia in him, but not enough to kind of take us down that route after maybe observing for a day or two. Dr. Gilman? Oh yeah, Dr. Gilman. Hey. Yeah.
Do you want to comment on the patient?
Yeah, just on that point of the differential. So I think one of the key things, so I had this patient on Tower 7. One of the key things that, and this is the reason I called you guys back, was because initially he was described as having delusions, that he wasn't a patient in the hospital, but it really wasn't delusional. He was not forming new memories, and there was like an obsessive compulsive kind of component to the repetitive nature of needing to kind of ask the same thing over and over again, and it was really a memory deficit more than anything. He wasn't psychotic, he wasn't overtly psychotic or delusional, and one of the reasons I would say that was true is one of the interesting things that was able to happen during the course of him being on Tower 7. Although he never accepted that he was a patient in the hospital, he was able to identify treatment team members as people who were caring for him. He didn't necessarily accept that he was a patient who needed a doctor, but he did come to trust those of us that he saw for many days as someone who he felt safe around. So it wasn't, you know, that he had a sort of different reality or anything. He just couldn't connect to what was actually happening, couldn't form that memory and that understanding. And so is that different than schizophrenia in that way, or is it just psychotic?
In that vein, could you comment on the difference between semantic memory and affect memory? Because patients who don't remember you in their words and stories clearly have a behavioral remembrance of you.
How do you want to deal with that? Or I'll take a shot at it. So I'm a neurologist. I feel I share with David very often my admiration, I'll put it that way, for psychiatry because it's so difficult. I often say you deal with stuff that's not understood. You're dealing with abstract concepts, and as soon as it's understood, it becomes neurology. As long as it's not understood, it's psychiatry, and that's, we both live in that world. And I'm glad I'm in this world but that's the way it is. So my heart goes out to you. I think anatomically. Okay, a neurologist thinks anatomically. That's what we do. Okay, so my question is, what part of the brain is involved? Okay, and that's what I'm going to be doing. And I think the right-left asymmetries are incredibly important. Again, Ani and I were talking about in between the grand rounds, we were talking about what does it mean? I often ask our residents, what does that mean? If I say the person's left hemisphere dominant, what does that mean? It's a much more complicated question than you think, and it makes you start to think about what is involved in language, as well as actually has to do with dexterity more than anything else. The very word dexterity means right-handed. Okay, in French, left-handed side is gauche. Okay, it's not right. Okay, so at any rate, my answer would be that the left hemisphere, insofar as language is divided, a simple way of thinking about it, which is often very useful, okay, is to think of the left hemisphere as semantic. Okay, it has to do with vocabulary and grammar, but the right hemisphere has to do with prosody, with rate and rhythm. So I use this example all the time, and I say, we should go now, or I say, we should go now. Okay? Are those the same thing? I mean, does anybody think they're the same? They're not the same. Okay? But the words are identical. The grammar is identical. So then from the left hemisphere's point of view, it's all the same. Okay? But the right hemisphere is going, they are not the same. Okay? They are very different from one another. So there is a recognition that there is memory for information, and there is memory for process. Okay? The non-dominant hemisphere, typically the right hemisphere, is going to be an attentional mechanism, and it's going to be it's going to be looking at sequential things a lot more than the information, which is driven primarily in the northern hemisphere. That's how I think of it. Now, I will say that I am just pleased as punch to have Ani joining us, because in the discussions that we've had already, she's going to dissect that simple-minded way that I have and go, oh no, you're doing black and white here. I mean, this is a color palette, okay? And we're gonna see a lot more nuance, I think, out of Ani, and I think she will be just a great glial cells between our departments. And by the way, let me just say with one thing. In terms of left and right hemisphere dominant, it is the best theory that I have seen is that this has to do with feeding behavior. There are several, if you go back for birds, for instance, see, the key of eating in nature is two things. It is to find and eat what you want without eating what you don't want, so picking the seed out from the dirt. And the other part of it is not being eaten while you're eating. Okay? So therefore, you have one eye, so in birds, the right eye, remember, birds don't have binocular vision, right? They have their eyes are out on the side of their head. So this eye is down, right? The right and it's looking at detail of the food, okay? But this eye is looking for novel stimuli that don't belong in the environment. That's what it's doing. It's just paying attention and looking for novel stimuli. If you look at the orca, this is the killer whale, okay? All the scars of battle are on the right side of its jaw because orcas attack from to their right, okay? We eat with our right hand. We throw a rock and kill the bird with our right hand. That's what, this is a feeding behavior, okay? It's basically where it starts. And the language, why exactly the semantic language developed over there? Well, oral, eating, oral, I think they just come together, but it is still the case that it is our non-dominant hemisphere who's constantly scanning and looking for novel stimuli. That is true, okay? And we retain that. And so that's the best theory that I know.